case, and available as well is matched with the catheter inside. But if you go for a delay phase, you will appreciate the tumor that was on the urinary bladder. You look at that's the film defect from here on the left lateral. So actually, this was a very advanced disease. And then after undergoing the MAID protocol chemotherapy, and upon check cystoscope and a control CT scan, now you can see the image of the CT scan after, and this is a plane. Yeah, this is a plane. So you can see, but if you want to look at the lung window, you see the lungs, they're okay. No in a nodule, no in a fusion. And on the other, there's no any hyperdense lesion in the liver. The ascites subsided, so there was a radiological improvement and cured of the treatment after chemotherapy with a MAID protocol. And this is, you can see the urinary bladder. Initially, the tumor were along this part, but after TBT and chemotherapy and check cystoscope, there was no any signs of the tumor. So so we wanted to present this case that was successful treatment of metastatic sarcoma. In very short, that sarcoma, one of the malignant soft tissue neoplasm that exhibit skeletal muscle differentiation, and this is a very commonest disease in the childhood, where sarcoma seems most of the common presentation, but it's very rare in adult. And in childhood, they account for 7% of childhood malignancy, and most common of sarcoma of the childhood. About 20 cases of the child sarcoma, they occur in genitourinary tract, vagina, bladder, prostate, and uterus. And this is the most commonly seen in the head and neck region. So the genitourinary tract sarcoma in adult is very rare, account for 1%. Then positive inflammation, constant contemporary management. So most of these bladder tumor, they have three subhistological subtypes, which is embryonal, pleomorphic, and alveolar type. And between these subtypes of sarcoma, they show a different immunohistochemical expression for desmin, myogenin, and myod1. So for our cases, it was strongly positive on immunohistochemistry myod1, and it was a botrade type of rhabdomyosarcoma. But most of the literature, they show they are chemo resistance. But surprising to our cases, it was chemosensitive. And so one of the conclusions of success, a list of the metastatic bladder cancer, embryonal sarcoma, which we treated with, it was muscle invasive bladder cancer with a TURBT and adjuvant chemotherapy. So this is a call for a more multidisciplinary approach, and probably establish our own local guideline with a team from pathology, oncology, etc., urologists, etc. So this is the summary of the first case. I'll go for the second case report, and we can proceed if the AGM. Okay. So this will be another case report with a successive posterior urethroplasty with Glasell's muscle interposition and VY gluteal flap for perineal gap wound following abdominal perineal resection. So we received this patient from general surgery, actually from the gastro team. This patient underwent, he had an colorectal cancer and he underwent neoadjuvant chemoradiotherapy. And then later on, he went there again for APR resection. So they did the APR resection with a colostomy. But 2 weeks later, this patient started complaining of urine leakage, papillary wound gap. So they transferred this patient to our facility, to our department. And subsequent, this patient had a perineal gap wound with a significant urine leakage. So after a couple of weeks, dressing, antibiotics with a series of culture, blood culture, and everything, we are planning to take this patient for cystoscope, PUA, and biopsy. And intraoperative finding that cystoscope, we revealed there was a normal anterior urethra with a good coaptation of external urethral sphincter, normal verumontanum. But just right after the verumontanum, there was a fistula that was communicating between the left pala verumontanum with the perineal gaped wound. And it was about 2 by 3 centimeter. It was wide enough. And the tissue around the fresh that fistula were very fragile, but we freshened and we took some for histology, which subsequently revealed the chronic inflammation. Now, for quite a while, we had again a couple of weeks of dressing, and now we decided to do urethroplasty that was involving the posterior urethra with significant gap wound post APR. So we did this by using the technique of Glacellis. So at first we were able to harvest a Glacelli muscle, the flap, and we subjected it to the perineal gap. And but just before that, we were able to repair the posterior urethral defect, and then we put our Glacellis muscle flap and position to it, and then we, because of the significant gap when on the perineum, we had trouble closure the perineum. So what we did, well, from the first picture you can see, we did VY gluteal flap, and the first picture, sorry, after just putting the after interposition of the Glacellis muscle, and then we did a VY gluteal flap to cover the perineal gap. So this patient stayed in the ward for a couple of weeks, and then we discharged the patient. But this patient still had an SPC with an colostomy. He had some also some amount of urine that were passing pyrethra, and this was 3 months post Glacellis interposition and the VY flap gluteal. And there was a very small minor gap here, you can see. Sorry. Yeah, so the posterior urethroperineal fistula, which was layer and it was iatrogenically, it's one of the devastating disease that posed a very serious challenge to the surgery. And most of the surgical experience in this case from the use of the augmented posterior urethroplasty repair, and from other researcher investigator, they also use the augmented with other probably graft and plus the flap of the glass cells. But on our side, we only did flam, glassine muscle. But all of them, they're acceptable treatment that will result for patient with the same presentation. However, more research needed in the fistula studies regarding the evaluation of patient. And another challenge that we had was patient sexual and urinary deficient uh, post that, but we are uh, continuing follow the patient to address that issue. So the use of the Gracil's muscle flap and posterior vessel past fistula opening a gap one is effective in collection of the defect and and good outcome that was revealed to our patients. So this marks the end of the second presentation. Thank you. For So I'll finish up with the third case report that where I do approach treatment of a leiomyoma of the urinary bladder, the experience from the tertiary hospital. And this was a 39 years old female who presented to us with a 1 year history of total hematuria, passage of blood clots and ovary shape, had a huge urge incontinence, nocturia, and straining during urination. Had a feeling also of incomplete bladder emptiness. She was mild anemic, febrile, not in a proper peripheral phenon, um, provisional revealed the anterior locate cervix. So we had a provisional diagnosis of bladder tumor. So the KUB ultrasound revealed the urinary bladder that was distended with a mass located at the base, measuring 4 times 4 centimeter. Um, so after that, we go for cystoscope, UM biopsy at first. Then we took a biopsy, then which revealed leiomyoma, and then we went again for TURBT, which we found there was a tumor from the left lateral wall at 3 o'clock, extending to 5 o'clock, and also part of the bladder neck, and the tumor was very solidly is bleeding with irregular uh, irregular margin, bladder mucosa that was normal. So as I said, the first TURBT was for diagnostic, although the patient still complained of the roots. So this was a second TURBT. So what we did did TURBT, we resect the mass, but then this mass were we could not be able to extract from the resect completely because there was the tumor was somewhat pedunculated and it was falling to the urethra. So we also had to complete the resection with aid of a vertical urethrotomy after TURBT, and because of the tumor was put into the urethra, so we complete the excision through urethra due to extension of the tumor to urethra. So this was one of the histological picture which show I can't predict my cancers, but here depict the normal urinary bladder epithelium, but because the slide was too large, the second picture, which showed the infiltration and was composed of the stroma, spindle cell, with the cellular proliferation, the vesicle elongated head with the xenophilic cytoplasm. There was central located cigar-shaped nuclear and inconspicuous nucleus. There was no any cellular tibia and abnormal mitotic figures that was finding. So these findings were in keeping with the diagnosis of inner beta leiomyoma. And when you look at this green arrow, this was the only epithelium that were normal. In this, the rest that leiomyoma that was infiltrated the unit beta. And this tumor was starting from the unit beta muscle. So we were able to complete tumor resection, TRBT, and vertical erythrotomy. And leiomyoma, this is one of the rare benign tumor of the mesenchyma that are most commonly benign tumor of the inner beta, and it represents 1 to 5%. And among these leiomyomas, they account 35, and most common benign myoma in the bladder, and therefore 0.23% of all tumors. And these are very rare, and only 250 cases that were previously reported, but we could not find this from Tanzania, probably because most we usually don't document it. So most common presentation are usually obstructive and irritatives, then hematuria, and one of the initial investigation, ultrasound, and later on CT scan or MRI is necessary for the surveillance of the upper tract, possibly with the of the tumor location in relation to urological orifice, and also cystoscope and other investigators also explain the tend to show tumor which is larger with a smooth surface, sometimes difficult to pass to the urinary bladder because of the huge. And they also report of being excised transvaginally. But for our case, we did the vertical thoracotomy as for our case, and for tumor completion and resection. So both approach were necessary for the complete excision. And sometimes we might distinguish intramural from endovesical tumor, and most of the endovesical tumor are the results of submucosal growth of the myoma. And this was first described by the Campbell and Gislonson. They usually polypoid and pedunculated, while most of the intramural bladder myoma, these are well encapsulated lesion and the surrounded bladder wall muscles. So endovesical form will usually mostly cause irritative and obstructive, and glossy hematuria resulting from relative diagnostics. So if you have a small tumor, they are far less asymptomatic. Yes, so most of these tumor, endovesical tumor, intramural and extravesical, which give different presentation, can close to the brain and neck, and some the urethra and present with renal retention. So they are surgically excised, and sometimes they do approach with either TURBT, and it's very important. They have a very low recurrence rate and symptom free, and they have a very good prognosis. They have low recurrent rate. So thank you. This marks the end of the third presentation. So I welcome if there's any question or any comment.
So question for all the 3 case reports. If there are any question for all the 3 case reports he presented.
Yeah. So I have a very simple question to Chilolate about rhabdomyosarcoma case. I'm thankful this patient responded well to the treatment. I was so much surprised. Anyway, I just want to know what's the timeline between the diagnosed time and the time when she completed the treatment, and up to now, what's the timeline? And now, in your opinion, now, what's the prognosis now for this patient?
Okay, thank you. So, from the time of diagnosis, currently now it marks 2 years since the last chemotherapy. So, for 1 year and almost half, we were seeing this patient post-operative with a check scope.
Have you seen him recently?
I think the next appointment will be in July. Yes.
So are you declaring this patient is surprisingly cured?
Yeah. When you look at most of the literature, for the metastatic disease, the survival rate is more than 2 years. So almost there. So we hope. I cannot really conclude, but okay.
Very lucky.
Thank you. Any other question? Thank you. So if there's any questions or comment, probably we can wait for the AGM. And thank you again.
So as from the timetable, it can be seen that we are left with only two presentations which are not from the sponsors. The one for Dr. Amini Mitamo and Salim Sobo. So I think when they are still finishing up with the media people, we can do those two presentations before AGM. So Dr. Salim Sobo and Amini Mitamo, if you are around, please.
Yes, good afternoon. I am Dr. Amini Mitamo Alexandre. I am a third-year resident at MUHAS, and I would like to present a case report which has been submitted for publication. And the case report is on adult Wilms tumor with inferior vena cava thrombus on a Y-type duplex collecting system that was managed at Muhimbili National Hospital. And I would like to thank the primary surgeon who was Dr. Gabriel Mtaturu, and also our supervisors, Professor Charles Mukoni and Professor Obadia. So Wilms tumor is also known as nephroblastoma, and it is mostly seen in young patients, especially under the age of 5 years. And while it is recognized as the most prevalent renal neoplasm in children, it is infrequently seen in adults with an incidence of 0.2 per million, which is equivalent to 70 newly diagnosed cases annually in Europe. The definition of adult Wilms tumor is to be met according to Kilton criteria. And these criteria include, first of all, the confirmation of a tumor, which is a primary renal tumor. The second is the presence of round cells or primary blastemic spindle component. The third is the presence of abortive or embryonal tubule and glomerular structures. Fourth is the absence of typical areas indicating that it is a renal cell carcinoma. And fifth is the histological confirmation through visual evidence, and also we have to consider the age of the patient, which is to be more than or equal to 15 years. In the English literature, as of 2018, more than 300 cases of adult Wilms tumor have been documented. And among them, a few of them are presented with involvement of inferior vena cava. But also, Wilms tumor has been found in sporadic cases. But also, it has been also not with cases of genitourinary tract symptoms, sorry, the genitourinary tract anomalies. And here we're going to present a case of adult Wilms tumor with genitourinary tract anomaly in a context of a non-syndromic situation. So the case is about a 28 years old female patient who was admitted to our facility complaining of a flank pain and mass for about 4 months. And the patient had no hematuria or no any other systemic symptom. The past medical history of the patient was not remarkable, and the patient had no any family history of cancer or other medical issues. The patient was a non-smoker and no allergy and was not on any long-standing medication. So the patient, on admission to our facility, we did some investigations, and the first one was an abdominal ultrasound, which revealed a large heterogeneous mass at the lower pole of the right kidney. Also, the imaging studies was completed by a CT, a contrast-enhanced CT, which revealed a heterogeneous enhancing solid renal mass with areas of necrosis in its lower pole measuring 10 times 10 centimeter, with associated with an extensive tumor thrombi filling the renal vein and the inferior vena cava. The CT scan also revealed that the patient had duplex collecting system on both sides, but on the right side, it was a partial or incomplete duplex collecting system, and on the left side, it was a complete one. So here we can appreciate, you can see the CT images. The first one, we have pre-contrast images which show the tumor, and the tumor was located on the right side, sorry. And the second image is a contrast image, which also gives the imaging presentation of the tumor and the size, which was approximated to 10 times 10 around. So the second is still the contrast images, which show the presence of thrombi. I'm not sure if the image is clear, but we can appreciate the thrombi in the renal vein first on the right side, and also the inferior vena cava. And the last image number 4, it's still a contrast CT with which shows the normal excretion of the diseased kidney, the kidney which is involved by the tumor. So on this image, we can now appreciate the thrombi, which is filling the whole renal vein, but also it is seen in the inferior vena cava below the hepatic vessels. And according to this presentation, we can appreciate that this is a level 2 tumor thrombi according to the Mayo classification. Here you can see the Mayo classification of tumor thrombi in the context of renal tumor. And here we have the reconstructed images. And on the right side, we have a partial or an incomplete duplex collecting system, which is also qualified as a Y-type duplex collecting system. And on the left side, we have a complete one, which ends with two different ureters. So from this CT images, we came out with the conclusion of we suspected a renal cell carcinoma. So we did some investigations with blood workup. The patient had a level of hemoglobin of 10. He had no hematuria, no proteinuria, and the baseline biochemical tests were within normal range. And the estimated GFR was 71, which was normal. We did some metastatic workups, among which we did chest X-ray, which was normal, and also the echo was also performed, and the patient has a normal scan with an ejection fraction of 65%. So as I mentioned before, we had a provisional diagnosis of renal cell carcinoma. So we took the patient for an open radical nephrectomy. This nephrectomy was performed and was also completed by the vena cava, by a vena cava cavotomy. We opened the inferior vena cava to extract the thrombi. Before we did so, we started to appreciate the involvement of the inferior vena cava and the extent of the thrombi within the inferior vena cava. So we performed this extraction of the thrombi by just clamping the inferior vena cava, half of the inferior vena cava, and do the extraction and then repair the inferior vena cava wall. So the procedure lasted around 3 hours, and the patient received intraoperatively around 4 units of blood and was followed for the first day in the ICU, but later he was discharged from the ICU to the ward, and he had an uneventful post-operative course. So that on day 5 post-operatively, the patient was discharged. So the specimen was submitted for histology, and the result came out suggestive with features of Wilms tumor, and this was confirmed by the positivity for immunohistochemistry, Wilms tumor 1 and PAX8. Both of them were positive, and these are histological findings for this particular patient. So for the outcome and follow-up, the patient was sent to oncology for an adjuvant chemotherapy, and the patient was admitted to ifosfamide and a toposide and Messner. Messner is not, it was just to prevent the complication of ifosfamide, which complication is mostly the hemorrhagic cystitis. So after a follow-up of around 4 months, the patient demonstrated an excellent tolerance to chemotherapy and exhibit no any symptoms, and he was clinically stable. So this table here presents some cases of isolated Wilms tumor on a duplex collecting system. So for our particular case, we have 2 situations which make it a very rare presentation. First of all, it's an adult Wilms tumor with inferior vena cava involvement, inferior vena cava thrombi, And secondly, it's a Wilms tumor which was developed on a duplex collecting system. So in the literature, we could just find the 6 studies, 6 case reports with a similar presentation of development of a Wilms tumor on a duplex collecting system. And here we can see the ages of the patients. Most of those cases are pediatric cases, mostly seen in female, and only one case of partial duplex collecting system, and with almost a ratio of 1:1 distribution of the side of the kidney, the side which was involved. Left side, we have 3 cases, and right side, 3 cases. So in conclusion, in adults, Wilms tumor is often initially misdiagnosed as a renal cell carcinoma due to the absence of distinct radiological findings. It is very difficult to distinguish the renal tumor, the Wilms tumor, from the renal cell carcinoma. So most of diagnoses are made postoperatively by submitting the specimen for histology. But if there was a possibility to pick it early, it is suggested to initiate the treatment by a neoadjuvant chemotherapy and then later perform the surgery. This is according to the SCOP protocol. So we have found increasing number of documented cases of non-syndromic Wilms tumor on a duplex collecting system. We thought this can be, the 2 conditions could share a common pathogenesis rather than being just a coincidence. So this hypothesis is to be clarified through future studies. Thank you.
So we'll finish up with Dr. Sobo and then go for the AGM. I believe everybody has cross-checked the names for registration for certificates.
Good afternoon. I am Dr. Salim Sobo, resident from MUAS Year 3. I'm going to present another research that I prepared. It's a research that I prepared for my MMed program that I'm still working on, which goes by the title of Would Utilization of Urethral Stricture Score, the U score, predict the outcome of patients undergoing anterior urethroplasty at Muhimbili National Hospital? This is a retrospective cross-sectional study, and my supervisor is Professor Charles Mkonyi, and co-supervisor is Dr. Francia Mushi. So on the background, urethral stricture is a narrowing of the penile conduit through which the urine is evacuated from the bladder to the outside, hence making it difficult or painful to be emptying of the bladder. Urethral stricture is a common condition at high incidency in the world, with estimated prevalence of 229 to 627 per 100,000 cases. It is a disease with a prevalence of about 200 per 100,000 in young men and more than 600 per 100,000 in older men over 65 years of age in the US. So several surgical techniques are available for the treatment of anterior urethral stricture. The choice of surgical technique, that the choice of urethroplasty type, is largely dependent on the severity of the stricture disease. Hence, the U score was developed to determine the type of surgery needed for the different stricture patient. So at MNH, about 95%, 95 patients underwent anterior urethral stricture repair, that is urethroplasty, from January to December 2022. Age range from 5 years to 97 years. So, just to give a brief introduction of the U-score, this is a score which was developed which utilizes 4 parameters, that is length of stricture, location of stricture, etiology of stricture, and number of stricture, which once the patient is scored and these are tallied up to sum up and give the sum up, then the minimum score for the U-score is 4 and the maximum score is 9. The cutoff is 7. So 7, 8, and 9, that is higher score. 4, 5, and 6, that is low score. So as you can see, it has, for the location of stricture, there is bulbar urethral stricture, that is 1 score, with penile stricture, penile urethra, 2 score. Number of stricture, if it is single stricture, is 1 point. If it is multiple, that is 2 points. For the etiology, if it's traumatic or iatrogenic, then it's 1 point. If it is inflammatory, infectious in deep, that is 2 points. Length of stricture, less than 2 centimeter, that is 1 point. 2 to 5 centimeter, that is 2 points, and above 5, that is 3 points. So the problem with statement is the stricture burden. Among stricture diseases, anterior urethral strictures have contributed about 84.5%. This was done, this is based on the study that was conducted at KCMC by Professor Mteta and others, which showed the prevalence of 84.5% among stricture patients. They are contributed by anterior stricture. Moreover, the knowledge of proper catheterization, we believe that if we educate medical personnel for proper catheterization, we reduce the burden of iatrogenic cause. And eventually, at currently MNH practice, there is no formal method of grading stricture complexity to guide the choice of surgical intervention and predict urethroplasty outcomes and the complexity. So we believe by implementing this U-score, we'll be able to certify stricture disease. So believing that the rationale of this study, the results of this study provide evidence-based information on the finding of significance of using the U-score in predicting the outcome and complexity of anterior urethroplasty, hence provide the best choice of urethroplasty as to minimize complication and improve outcomes. Moreover, the results will help in perioperative counseling of the patient before they underwent urethroplasty, hence influence surgical decision. Even a patient can be cancelled. Moreover, eventually this will have a standardized score. It will be a standardized scoring system that will allow stricture-related research to be reported in a common language among researchers from different centers. So objectives, the main objective was to determine the significance of U-score in predicting the surgical complexity, length of hospital stay post-surgery, and post-operative complication for the patient who underwent anterior urethroplasty at MNH. The rest were just minor objectives, that is to determine the types of urethroplasty that are happening at MNH, determine the outcomes of patients post-urethroplasty, and eventually the association of U-score with surgical complexity, length of hospital stay post-surgery, and post-operative complication for the patient attending MNH post-surgery urethroplasty. Methodology, the study design, this was hospital-based retrograde cross-sectional study that included a study population of 179 patients, and the sample size was calculated by using Leslie-Kish formula with a non-prevalence, and the proportion was obtained from the study of Professor Mteta at KCMC, which showed the prevalence of 84.5% of the all stricture that we contributed from anterior stricture. Data collection, as we all know that the standard diagnosis of urethral stricture is ureterogram. So our study relied on the findings from the ureterogram, which was cross-matched with the findings from intraoperatively, that the length, location, and the number of stricture were calculated from the ureterogram and verified by the surgeon intraoperatively. Etiology of stricture was extracted from patient's file. Surgical complexity, post-operative complication, recurrent stricture, and the duration of hospital stay was assessed as an outcome of our interest. To classify surgical complexity, we used the criteria done by the study of Evsuara and others, that we use low complexity to be defined as excision and breval anastomosis, buccal mucosa grafting, be it single stage or multi-stage, And higher complexity were defined as the use of double mucosa grafts, use of a flap or a flap and graft combination. Analysis was done by using SPSS 25th version. Chi-square tests were used to assess categorical data, and t-tests to analyze continuous variables. The relationship between U-score and surgical complexity were determined by t-test with a U-mean score of 8 with both low complexity and high procedures and high complexity procedures. The association of U-score and the outcome of our interest was done by using chi-square test, and logistic regressions was used to assess the adjusted predicted variable effect. Significance value was determined to be less than 0.05. So the results. From the clinical demographic characteristics, we've seen the comorbidity with a median age of 51 years of age with a standard deviation of 19.8. Comorbidities, as you can see there, we categorize the most common one were hypertension, diabetic mellitus, HIV, multiple, and others, as multiple as others. Stricture characteristics as the main U-score parameters. The location of stricture that was for the anterior strictures we are doing, it is bulbous urethra and penile urethra, and moreover we went deep to categorize them from distal bulbar, mid bulbar, or proximal bulbar, and for penile urethra we categorize them in proximal or mid penile. And the numbers, as you can see. From the numbers there, you can see out of 179 patients files, almost 145 patients had bulbar urethral stricture, while 34 patients, that is almost 18%, had penile stricture. Moreover, on the number of stricture, almost single stricture were 170, and only 9 patients had multiple stricture. On the etiology, most of the strictures were traumatic compared with infectious or inflammatory, with very few to be idiopathic. Perioperative characteristics, as we said, low complexity and high complexity. You can see here almost 93% of patients had low complexity, surgical complexity, and only 6.7% had high complexity. The type of urethroplasty that was conducted, majority underwent EPA, followed by single stage and multi-stage. Double mucosa graft, double BMG was done only for 9 patients, and graft and flap combination for that period of study were not available. And the duration of length of hospital stay was calculated in days. That's median was 5 days with a standard deviation of 2.5 days, and the length time of surgery were 2.5 hours. Postoperative complications were only 27 out of 179. The complications that were observed, majority were surgical site infection and bleeding, was defined as postoperative anemia. Recurrent stricture were 9 and others were 12, contributing those percentage. The U-score characteristics, as we define the low score and high score, we can see here 165 patients had a low score, while 14 patients had a high score. If you compare this data with the patient who had higher complexity, we're expecting the higher the complexity, the higher the score, and the lower the complexity, the lower the score. You can see out of 165 for having low complexity, we had 167 patients with low complexity, which means 2 patients with higher complexity than underwent low surgical complexity. These are the scores, as we said, the distribution of the score, 4 to 9. So 76 patients, almost 42% had a low score of 4, as distributed in the table there. So after having the data, we went on analysis. We had to break down the parameter, each parameter of U-score, that is the length of stricture, location of stricture, etiology, and number of stricture, so that to see the strength and or the capacity or the contribution of each parameter on the U-score. As you can see here, stricture location, here we compared the stricture location and our outcome of interest, that was surgical complexity. The location of stricture, bulbar stricture was protective. As you can see, the odds ratio showing that 0.34, which means that patients with bulbar stricture had less surgical complexity compared to penile stricture. Moreover, up with a p-value of less than 0.05. Moreover, on after doing adjustment, you can see the adjustment odds ratio of 0.05 with an interval of ranging from 0.1 confidence interval to 0.01 to 0.1, and the p-value remained to be less than 0.05. So it is from this parameter you can see the contribution, the strength of location of stricture in the U-score in predicting surgical complexity. Moreover, number of stricture patients who had single stricture had less surgical complexity compared to those with multiple stricture. This was evidently seen with a low p-value that was showing that to be statistical, to be relevant. But unfortunately, after controlling the confounders, you can see here, after controlling the confounders, the p-value we obtained to be 0.4, which was not statistically significant. On the etiology, traumatic versus infectious, it has been shown here that patients who were traumatically were prone to have surgical complexity, higher surgical complexity compared to those who were traumatic. So by etiology, traumatic strictures were being protected over here, and the p-value of less than 0.05, both in a control, after controlling, before controlling and after controlling the confounders. Length of stricture also, one may ask here, the real U-score had 3 parameters. They categorized the length of stricture in 3 groups, from 0 to, less than 2 centimeter, 2 centimeter to 5 centimeter, and above 5 centimeter. But over here, I had to dichotomize this parameter so that to have easy analysis and easy interpretation, and moreover, we had very few patients who had stricture lengths more than 5. So I grouped them and I did dichotomization of this parameter. And you can see here, the shorter the stricture to be a protective factor against surgical complexity. As you can see, 0.4, that was the odds ratio, and with a p-value which was significant, it was less than 0.05. And even after controlling the confounders, remained the p-value to be less than 0.05. And also we did an association of U-score vis-a-vis surgical complexity, and the results were the lower the U-score, the less the surgical complexity, and showing to be a protective as well. We also went further on comparing the U-score vis-a-vis post-operative complication. So again here we had to break down each parameter and see and measure the strengths of each parameter on its contribution vis-a-vis our outcome of interest. And you could see here again the penile stricture to be, bulbar stricture to be protective of surgical complexity of post-operative complication, that patients who had bulbar strictures had less post-op complications compared to. So, moreover, we went on with U-score vis-a-vis length of hospital stay post-surgery, and showed to be statistical significance, having low patients who had lost U-score were showed to be protective with an odds ratio of 0.4. So, conclusion, this study brought to light that substantial influence of the use of U-score to predict the capacity of surgical complexity and post-operative complication for patients who underwent anterior arthroplasty. And these findings will be useful for perioperative counseling of patients, and might influence the patient's decision to undergo a more successful definitive procedures as perineal ureterotomy, and compared to less or more complex surgery. It is also enhanced an understanding of the burden of post-operative complications and the common complications that we usually encounter post-urethroplasty. Recommendation, limitation of this study, it was a hospital-based at MNH, so it represented only a fraction of urethrostricture patients in Tanzania. So this is a limitation. Moreover, the study was retrospective in nature, so believing that if it was a pro, it would be more efficient. On recommendation, based on the study findings and discussion, I would recommend the utilization of U-score for MNH patients who present with anterior retrosthesia who are expecting to undergo anterior retroplasty. Thank you for listening.
So can we have a few questions for Dr. Sobo and Dr. Amini before we go to the AGM?
Thank you very much, Dr. Sobo, for a nice presentation. I have one question. How was the length of a stricture measured? Was it on urethrogram or we are measuring during urethroplasty? If it was during urethroplasty or during urethrogram, was there a correlation between the two readings of, that means the measurement from urethrogram and the measurement during urethroplasty? Thank you.
According to the study, what we did was we measured by urethrogram and confirmed them intraoperatively. Because sometimes during urethrogram, if the technical error happens and intraoperative findings may be different, so we compared both intraoperative and before, that is urethrogram, we utilized it.
Yeah. Thank you for a nice presentation. My question is, what is the definition of complexity in your study? And is there any patient who underwent complexity in among the patients?
Yes. We define this surgical complexity as the need for the following procedures. That is, types of erythroplasty. If it is excision and primary anastomosis, single-stage BMG, multi-stage BMG, these were low surgical complexity. So this criteria was taken, we adapted it from the study which was done by Swara in Egypt. And also for the utilization of flap itself. If any patient undergoes urethroplasty by utilization of flap, that is high complexity. Or flap and graft combination, that is higher complexity. That is how we define surgical complexity.
Sorry, if I get well, there was no patient who underwent flap and graft on the same time in your results. Is
yes,
it so?
Yes, so for the period of patients who underwent that period.
So I don't think you can conclude that this score, because there was no patient to compare with versus complexity and the patient did not undergo complexity. So it's like you had only patient who had low surgical complexity. So that is my overall comment.
There are patients who had double BMG. So if the graft was used twice, the stricture location had multiple. So as you can see here, there was a double BMG. Double BMG also is considered to be high complexity.
Okay, thank you for the presentation. I have a few comments or remarks to make regarding what you've just presented. One, the outcome of urethroplasty evidently also depends on surgeon's experience, who is doing the surgery, how experienced they are. Another one is, are they doing it at a high volume or low volume center? It also determines the outcome. And thirdly, is it a primary surgery or a redo surgery? So I don't know, does the score also, in one way or another, put in consideration those factors? Are we talking about primary surgery or, because I did not see you capturing a redo surgery at any point, so I don't know if you excluded those patients who were having a redo surgery in your study. So maybe those are the factors that I've put in consideration as well. Thank you.
It was a little bit difficult to compare surgeons. You know, junior surgeons vis-a-vis experienced surgeon. The same MEPA can be done within 30 minutes by an experienced surgeon, while for a junior surgeon, it may take 2 hours. So I took it as a confounder. I wish I could present the conceptual framework. I put that surgeon's experience as a confounder in the conceptual framework. But I feared to it of interest.
And about the redo surgeries? Redo surgeries, like secondary, it was done before it failed and then you're doing it again.
Yes, recurrent stricture. I defined the recurrent stricture as the need for redo surgery or secondary procedure. That's how I define it.
Any question for Dr. Amini? If no any question, I think we can end up there and go for AGM. And then when we finish AGM, we'll have presentation from the sponsors.